Okay, so without further ado, I'm going to try to give you adult congenital heart disease in 15 minutes, which doesn't actually happen. So I'm going to try to focus on two major lesions, okay? Um, so unfortunately, adult congenital heart disease is rising, and it's rising very quickly. And unfortunately, the major problem is that we haven't been prepared for the success, right? About basically 60, 70 years ago, if you were born with transposition, you were going to die. You were probably going to die within the first month of childhood. It's possible you might have died within the first few hours of birth. In fact, most of the time what happened then was the baby was delivered, the baby was put on the mom's chest and said, enjoy the baby while you can for the next hour because the baby's going to be gone. On the other hand, now we have patients who are surviving into their 5th and 6th decades with transposition of great arteries, which is miraculous. But the problem is, just like you and me, they all think they're going to live forever, okay? And they don't see their doctors, and after they leave their pediatricians at age 18, they stop seeing them. So this is how they're going to show up. This is you and me sitting in the emergency room waiting for that next admission. So they're going to show up with unrepaired Eisenmengers and really sick. They're going to show up with repaired ASDs and now pulmonary hypertension or rapid AFib. They're going to show up with transposition and an atrial switch procedure and a failing right ventricle. They're going to show up with tetralogy flow with a failing RV or a failing LV. They're going to have recurrent coarctation, and it will happen. It will even happen in your patients who have had a transplant, because remember, when you get a transplant, you don't remove the coarctation. So we have had a number of patients who have actually had recurrent coarctations after their heart transplants. You're going to see a bunch of Rosses that are going to have some serious problems. We mentioned a little bit of that in conversation yesterday. And then, of course, the real problem is we're going to have a lot of single ventricles without a clear plan. And then, of course, you're going to see a bunch of these patients with a number of these lesions that are going to have paradoxical embolism because a lot of them are going to have right-to-left shunts that are uncorrected. And if this is ABC, alphabet soup to you, that's okay. That's what it was to me because we didn't actually have an adult congenital program where I did my residency, so I had to learn everything during fellowship. But what I'm going to focus on is a couple of different things. Here's the other thing that you really need to know, okay? So in dark gray is the admissions to the hospital for adult congenital heart disease, and light gray is pediatric admissions to the hospital starting in 1998. And as you can imagine, things are shifting very quickly. And that's because, at this point, because of the survival curves, we have now more adults with congenital heart disease than we have kids with congenital heart disease. And so you can imagine this is actually going to flip-flop very quickly pretty soon. It turns out that if we make a proper estimate, we may have up to 1.5 million adults with congenital heart disease, and that number is going to continue to increase 5% annually. It turns out that if you look carefully, there may be 1% of live births that are affected by congenital heart disease. And when you really think about what that means when you project that over normal life expectancy, that's possibly 60, 70, maybe even 80 years of lifetime exposure to a disease. The other reason why we're seeing it now, and the other reason why it's important that you start learning about it now, is because history has everything to do with why we're seeing them. So it wasn't possible to survive tetralogy flow, severe tetralogy flow until 1944 with the advent of the Blalock Tausig shunt, Tausig, right? So in 1944, they were actually able to start correcting these blue babies. Prior to this, if you've seen the movie, they thought it was anathema to operate on the heart. This was a huge change. Of course, it wasn't truly possible to really operate on the heart and do a good job until the advent of cross-circulation and, of course, the heart-lung machine. So how many of you guys know what cross-circulation is? Raise your hand. Okay, one person. So cross-circulation was basically where you took the mom or the dad and you hooked them up to the baby, and the mom and the dad, mom or dad basically functioned as the heart-lung machine for the baby. And that actually allowed the surgeon to open the heart and do a bloodless field when they were operating. Otherwise, prior to this, what they had to do was just open up the heart, open up quickly, put a finger on it, repair it, and then get out and close before the baby exsanguinated. It doesn't take much for a neonate to exsanguinate, as you can imagine. So a lot of kids died from that. So the advent of my field, which is interventional congenital cardiology, was in 1966 when Bill Rashkin developed the atrial septostomy. Prior to this, for patients who were born with transposition of the great arteries, in order for them to actually get mixing of the cyanotic versus oxygenated blood flow, the surgeon had to get in there, do exactly what I said, open up the heart, rip a hole in the atrial septum and close it before the baby exsanguinated. Remember, the clock is ticking the moment that transposition baby is born and disconnected from the placenta, right? So it's not uncommon to see the baby have a pH of 6.8 when they arrive for repair. But what balloon atrial septostomy allowed them to do was to actually do this by catheter-based procedure, and I actually don't have too much time to talk about it this second, so we'll move on. Then, of course, the biggest advancement has, Uh-oh, it's not in my slide. The biggest advancement, of course, has been transcatheter valve, which has really hit in the 2000s. And as I'll show you in a minute, has been a huge boon for patients of mine. So let's focus on transposition. So this is what, actually Dr. Mamarian showed you a little bit of transposition. That was L transposition. This is detransposition of the great artery. So how does this actually work? Turns out it's actually pretty common, and it's probably overrepresented because these patients are going to keep showing up because they're going to continue to have problems. It's about 5 to 7% of all congenital abnormalities, probably closer to 7%. As I mentioned, if you don't do anything, at least 30% of them will die within the first week of life, 90% within the first year. If they don't have an open atrial septum or a very large PFO, they probably will all die within the first hours of life. It affects about 20 to 30 of 100,000 live births, and there is a male to female predominance. So let me tell you how I got into congenital heart disease. This was actually during fellowship. This is a 28-year-old man with transposition of the great arteries, and I remember that being lethal in childhood. So I thought, well, how is this possible? Why is this guy even alive? Well, he had this thing called the Raschken septostomy, which I didn't really understand because I was seeing him in clinic and I didn't understand congenital heart disease as a fellow. He had sending atrial switch procedure, which I definitely didn't know. I had to Google that one. And then he had this thing about moderate systemic right ventricular dysfunction. I'm thinking, what the heck is a systemic right ventricle, and why is it dysfunctional, and why do I even care? You can't see it. So this is the right atrium, this is the right ventricle. Can you guys actually see that? Okay. Well, anyway, so this is how transposition of the great arteries works. You're going to have to pretend that this is the right side, which shouldn't be too hard. So the right ventricle gives rise to the aorta, and you have blue blood flowing through there. Which goes through systemic circulation and then comes back even bluer, right? Because now you've extracted oxygen off of it. It comes back to your SVC and IVC. So that's not a good situation, right? Because you continue to get bluer and bluer and bluer. And that's why you have these babies who are born with pHs dropping into the 6s very quickly after birth. And then the LV gives rise to the pulmonary artery, and the pulmonary artery goes through the pulmonary circulation, picks up more oxygen, and then comes back through the pulmonary veins and returns more oxygen to the left atrium, and the cycle continues. Okay, so because the circulation is in parallel, the baby starts to die the minute they're disconnected from the maternal circulation. So the Raschken septostomy was a goal to try to get around this, okay? And the whole point of this is to try to mix the blood flows, right? And so I've shown you this in purple. So the Raschken septostomy basically rips a hole between the left atrium and the right atrium. And the way we do this now is most of the time, because when these kids are born, we're able to cannulate their umbilical veins still. We go up through the umbilical vein, put a 6 French sheath in, and then advance a catheter through the patent foramen ovale, inflate a balloon in the left atrium, and rip a hole in the atrial septum. And immediately, the baby's stat starts to rise, the baby's pH starts to rise, and the kid actually survives, and their hemodynamics start to improve. The really scary thing is, as this is all happening, their hemodynamics start to drop, they start to become bradycardic, and they start getting sicker and sicker while you're working. So you have to move pretty quickly. And then, of course, a lot of times they have patent ductus arteriosus, which also facilitates some degree of mixing, but you really need the Raschken. So the atrial switch was the first major advancement in transposition in addition to the septostomy. So you've made mixing, right? That's great, but the kid's going to walk around 80% for the rest of their life. And that's how a lot of people survived for a while. But you want to have some sort of definitive plan for this, right? And so what the sending or the mustard procedure is the following. You take the SVC blood, the SVC and IVC blood, that venous blood, and you baffle it over to the left atrium, which then goes to the left ventricle, goes to the pulmonary artery, into the pulmonary circulation, gets oxygenated, then comes back red, and then you baffle that red blood over to the right side, using a second baffle, and that allows you to get this, the oxygenated blood flow into the right atrium, right ventricle, and out into the aorta, and supply oxygen to the body at that point, okay? And so now you've actually created a system in series. So the difference between the sending and the mustard is the following. The mustard was probably the more popular technique at the beginning because people didn't know how to do this, so they had to use bovine pericardium or other exogenous tissue in order to actually create the baffles. The sending was done using the patient's actual intrinsic atrial tissue. So what do you think happens when the baby grows? Well, it turns out that the exogenous tissue is not going to grow, and so mustard tends to develop stenoses over time, whereas the sending actually does better. And so over time, the surgeons began to catch up and start using the sending procedure more often. So kids who were born in the 70s, early 70s and late 60s, you'll have them all have the mustard. So my 40 and 50-year-olds have mustard procedures. Kids who are born in the early 80s and late 70s will have the sending procedure, okay? So going back to my patient, the 28-year-old that I was telling you about, who had all that stuff that I didn't understand. So he shows up, and this is how I meet him. He was playing on his softball team, and he's running from third base to home, and he was actually going to have the winning run when he suddenly collapsed. He had bystander CPR until the EMS arrived. There happened to be a physician in the audience, and he was found to be VF. He was defibrillated successfully, and a cooling protocol was initiated. And this is where we came in. So he came to our CCU, and I was asked to do a transesophageal echocardiogram on the guy, and I had no idea what I was looking at. And of course, he was totally devastated at that time after his VF arrest. And of course, we saw systemic RV dysfunction. So why does that actually happen? Let's move on. So here are the major problems, right? So at the end of the day, the RV is not meant to face systemic pressures, right? And so this is the load that your RV was never meant to take, right? When you have a patient who comes in with massive PE and their RV pressure reaches 100, they die, right? Same thing with your pulmonary hypertension patients. As they reach systemic level pulmonary hypertension, they die, right? But somehow these kids manage to make it up to adulthood, but then they start to have problems, right? And sooner or later, the systemic RV starts to fail. And that's exactly one of the things that happened to this guy. Many of them will actually develop sick sinus syndrome, possibly surgically related, possibly related to changes in the scar in that area. Many of them have atrial flutter, and unfortunately, atrial flutter cannot be ignored in these patients because they can degenerate into VF and sudden death. As I mentioned, the other major problem is sometimes sudden death happens and it has nothing to do with systemic RV dysfunction, so sometimes that can happen without any kind of warning. Major problems, as I talked about, is eventually the baffle will have a problem. Sometimes they can leak, sometimes it can stenose. And that's exactly what you're actually seeing here. So you can see this is the gigantic azygous vein, and actually what you see here is stenosis of the SVC baffle in this 3D reconstruction of one of my mustard patients. And the real dreaded consequence, which we don't see that often, is pulmonary vein baffle stenosis. Because again, as you can imagine, as that mustard, as the patient starts to outgrow that mustard, eventually they're going to have a problem, and then they're going to develop pulmonary vein stenosis. It's very hard to diagnose because they'll present with pulmonary edema, and sometimes it just looks like systemic RV dysfunction. So what's going to be coming around the corner for most of you is the arterial switch. So the first time they tried to do the arterial switch, they forgot to take the coronaries over to the neo-aorta. So all those kids died. There's 100% mortality. So they stopped doing it and then resumed doing it in the mid-'80s when they actually were able to start reimplanting the coronaries. Okay? So that's actually what happens nowadays. So most of those kids that you see that are probably 25 years and younger are going to have had an arterial switch. So this is what it looks like, right? So you switch the aorta and the PA, and then you move the coronaries over to the neo-aorta, and that's how things are going to work out the right way, and the kid's not going to die in childhood. So here's the problem, though. Whenever you reimplant the coronaries in a neonate, you're going to have a problem where you could potentially have kinking of the coronary arteries, and these patients will present with cardiomyopathy. Sometimes they'll present with chest pain. So don't ignore the 25-year-old who shows up in your ER with ST elevations and chest pain and a median sternotomy, because they probably won't know what they had as a baseline lesion. They probably won't know what surgery they had, and in all likelihood, they may have actually had arterial switch for their transposition. The other thing that can happen is because you're taking that PA from posteriorly and you're stretching it forward, they can develop pulmonary arterial stenoses. And so that's something that you want to look for when these patients present with shortness of breath, because that can always present later on down the line. And unfortunately, you're going to start seeing a lot of these because this is universally now the way we correct most of these patients. So in the last minute, I'm going to talk really quickly about tetralogy Fallot. So let's skip through this. It is the most common cyanotic heart disease, but what I want to get to is what problem you're going to run into. So remember, tetralogy Fallot is basically a right ventricular outflow tract obstruction and a VSD, and so therefore the patients are cyanotic. So during the repair, the surgeon has to resect out the infundibular stenosis, take out these RV muscle bundles, and then slice across the pulmonic valve. And then, once they've sliced across the pulmonic valve, they patch it as large as possible by doing this, what's called a transannular patch, and then patching the VSD. The problem is when you slice across the pulmonic valve, you are mandatorily going to require a pulmonic valve replacement at some point in life, okay? And so unfortunately, if you can imagine this kid getting a pulmonic valve replacement, they're going to need a replacement over and over and over through their lifetime. And my oldest tetralogy Fallot patient is 73 years old. Okay, so if you can imagine a lifetime of pulmonic valve replacements, that's a lot of trips to the OR. So let me skip this. this is a patient of mine who showed up with palpitations. These were his palpitations. So this is why pulmonic regurgitation is not benign, because eventually the RV will fail and you'll get VT. So I am out of time, but I want to sort of, Okay, that's his MRI. Let me skip to what ended up happening. So he gets a pulmonic valve replacement with a 27 millimeter St. Jude Epic. Okay, but the problem is he's 36 years old now. As I just mentioned, he's probably going to need a valve replacement again in about 10 years. So what are we going to do if he's only 36 years old? That's where this comes into play. And as I mentioned at the beginning, transcatheter valve has been a huge boon for these patients. So this is the Melody valve. It's a bovine jugular venous valve that's implanted via a balloon catheter advanced from the femoral vein. Okay, and it's designed specifically for patients like these who've already had 2 trips to the operating room. So as you can see here, they've done in the cartoon showing that it's being implanted in this particular situation in a homograph, but of course we can actually put it in all kinds of different bioprosthetic valves too. And so we hope we can avoid sending these patients to the operating room specifically for at least maybe 2 or 3 decades. And then, you know, if they needed to be reoperated on down the line, that's okay, right? That's acceptable for us, but at least we can avoid having them go to the operating room 5 or 6 times during their lifetime. So with that, I've way gone over my my talk. So thank you very much.